Hello, everybody. My name's Annabel Crabb, and I'm thrilled to welcome you to the Breast Cancer Trials Q&A on the topic of metastatic breast cancer. There are about 1,600 people on this session, which is just an overwhelming number and a great indicator of just how much interest there is. So I'd like to start just by welcoming everybody who's tuned in. I know that there's a whole range of people interested in this subject. There are people living with all kinds of breast cancer, people living with metastatic breast cancer, people who are very worried about getting metastatic breast cancer, and of course, people who are worried about the people in their life who they love, who are connected to or undergoing this situation. So, and there's professionals who are always looking to expand their expertise also joining us today. And I thank you so much for being here, because if you have questions that are scary, there is nothing better than having clever people to answer them for you in a way that leads you into the direction of light and information. So I'd like to thank our panel joining us today. Breast Cancer Trials is the largest independent oncology research group in Australia and New Zealand, and they've been conducting clinical trials research into the treatment and prevention of breast cancer since 1978. And this year, more than 20,000 people will be diagnosed with breast cancer in Australia and more than 3,500 in New Zealand. And it's estimated that about 5 to 10% of those will have metastatic disease. So Breast Cancer Trials has arranged this session to ensure that all those people know that they're not alone, and that there are answers and help out there, and very, very clever people working very, very hard to improve outcomes. So we're looking forward to answering some of your questions on this important topic. Before we get underway, though, I do want to acknowledge that I'm coming to you today from Ghana land in South Australia, but I know that there's people from all around Australia, from different parts of this continent, and also from New Zealand. And I want to recognise that we live on an ancient territory, which has always been trod for tens of thousands of years by people who are trying to eliminate problems and help each other and make their lives better. And so in recognition of that ancient tradition, we come together today, and I acknowledge the traditional owners of the land wherever you are. Right, so I'm going to introduce our guest panel. We're going to get to them sort of slowly one by one, and then we're going to tackle a whole bunch of questions that have come in from all of you towards the end. So I'm going to start by just introducing them. There's Professor Sarah-Jane Dawson, who's a clinician scientist, and she heads the Molecular Biomarkers and Translational Genomics Laboratory at the Peter MacCallum Centre in Melbourne. Dr Shom Goel is a clinician scientist at the University of Melbourne and at the Peter Mac Centre. And Associate-Professor Lisa Beatty is an Associate Professor of Clinical Psychology at Flinders University and a visiting consulting clinical psychologist in medical oncology at Flinders Medical Centre in Adelaide. Honestly, I do not know how you people ever get business cards, because there's so much. See, I'm just a sort of travelling minstrel and idiot, so it's very, 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 very small, my business card. Anyway, look, just wanted to give you an idea of the kind of questions that come in when you ask people to ask whatever's on their mind about this subject of metastatic breast cancer. So just put together a little flavour of what people want to know. Here's a little video to show you. found that little collection so evocative, really, of the fears and anxieties and uncertainties of people who have been plunged often into a situation where they are absolutely without any bearings or context. And, I am the perfect person to be asking these questions today because my knowledge level is zero. And I often have realised while working as a political journalist that sometimes the dumb questions are the best ones to ask, because if you don't know anything, you've just got to say so and start collecting the information as you go. So Sarah-Jane, I'm going to just remind you that Sarah-Jane Dawson is a clinician scientist and heads the Molecular Biomarkers and Translational Genomics Laboratory at the Peter Mac Cancer Centre in Melbourne. Sarah, to you, I'm going to direct the question that I would have if I got this news, which is, what is metastatic breast cancer?
Hello, everyone. So metastatic breast cancer is really the term we use to describe when breast cancer has spread or metastasized to another part of the body, away really from where it originated in the breast. So it's not an easy subject to talk about, but in essence, we know that breast cancer cells can spread to any part of the body, but they most often spread to certain areas of the body, and that includes the bones, the liver, and also the lungs.
And why does cancer metastasize?
Yeah, I think that's a good question and not necessarily an easy one to answer. So we know that metastatic breast cancer develops when breast cancer cells either enter a patient's bloodstream or through their lymphatic system, and those cells then get carried to other distant sites within the body where they can start to grow. Now, the reasons why the cells can do that and spread and start to grow in another area of the body are complex, and certainly still active research is underway at the moment to try and understand why in some patients metastatic disease develops, whereas in other patients it does not.
What is the most common way that it happens? I mean, are people with metastatic breast cancer most likely to find out about it at the same time they find out they have breast cancer at all, or is it a staged development?
So both those scenarios can be seen. So some patients are diagnosed with metastatic disease at the beginning of their cancer journey, whereas for others, they may be treated for an early stage breast cancer and then the disease may return over time. And
we often, this is where it gets sort of terrible, like it's got such a scary reputation, right? Like, we often hear that, well, metastatic breast cancer is not curable. But what does that mean, and how effective are the treatments that can keep the cancer under control, and for how long?
Yes, so there are actually many effective treatments now for patients with metastatic breast cancer, and the number of treatments actually continues to increase. The more research, the more clinical trials we're doing, those treatments are increasing all of the time. And because there are actually many treatment options available, for many patients, living with a diagnosis of metastatic breast cancer is actually like living with a chronic disease. So in many cases, women can live for, a very long time with a diagnosis of metastatic disease because there are many different treatment options available.
Okay, thanks so much, Sarah-Jane. I'm going to bring in Dr Shom Goel now. He's a clinician scientist at the University of Melbourne and at the Peter MacCallum Cancer Centre. Good afternoon, Shom. Thank you for... I just wonder what is the focus of research right now at the moment for metastatic breast cancer? Where is the amazing, interesting new stuff happening?
Annabel, metastatic breast cancer is a huge subject. And so the researchers around the world are approaching it from a lot of different angles. And what I wanted to briefly say up front to people here is that the good news is that the research that's going on is bringing real results. We're seeing new treatments being developed quickly, and outcomes for our patients are improving all the time. People are living longer and longer, and often with a reasonable or even good quality of life. So that's the great news. In terms of the type of research that people are focusing on right now, well, first there's the work that's done in scientific labs. That's what my team does right here. We're trying to understand how breast cancer cells work and find new drugs. Then there's the clinical trials where we actually want to test those drugs and see if they work. And then there's a lot of research into how to better manage the symptoms of breast cancer, the side effects of treatment and so on. And just to briefly talk about the scientific side, because that's where I'm coming from, I think there's a couple of big themes that are coming through right now. One of these is what we call personalized medicine. Everyone's very focused on this. And what that means is we now realize, and we perhaps didn't realize this before, that every cancer is different and also every patient is different. So there's a big focus on trying to find the right treatment for that specific cancer in that specific patient. I think another big topic that we all focus on right now is drug resistance. So we're really trying to understand why it is that metastatic breast cancer may respond to a treatment for a while, but then develop resistance and potentially become life-threatening.
Is that an attribute that's unique to metastatic breast cancer, Shom?
Look, it's something that we see in both metastatic and early stage breast cancers. Unfortunately for metastatic breast cancer, the vast majority of cancers do eventually develop resistance to the drugs that we use. In the early stage, that's when patients are diagnosed with breast cancer just in the breast itself. Actually, the vast majority of those patients are cured of their disease and don't experience a relapse, but then again, there are some who do.
Is there any, I mean, we all know that the last 20 years even has yielded just extraordinary results in the field of breast cancer research. And we know that even I think most of us know from our personal lives that a breast cancer diagnosis is not as frightening as it was 20 years ago. And I wonder what the historical pattern of metastatic breast cancer is. Is it more common now than it was 20 years ago? Is it has its treatment advanced in the same way that primary sorts of breast cancers have?
Yeah, it's a great question. So the treatment, as Sarah-Jane mentioned, the treatment options that we have come a long way. So, compared to what we were doing 20 years ago, it's a very different ballgame right now. People are living longer, as I said, and often living with better quality of life. There's a bit of a paradox in this, in that if you ask me, are there more people living with metastatic breast cancer at the moment? The answer is yes. There are more people alive in Australia with metastatic breast cancer today than there would have been, say, 20 years ago. But part of the reason for that is because people are living longer because treatments are working better. So there are more people who are going through this process at the moment and seeing it go for a longer time.
Late last year, at another session for breast cancer trials, we talked, it was a great conversation actually, about the side effects and the ways that people living with breast cancer deal with the implications for their body image, for their sex lives and all sorts of stuff. It was, I have to say, like a fantastically raucous discussion and really helpful. But like, how much research on quality of life and improving the side effects of treatment is going on?
Yeah, that's a really important subject. And, those of us looking after patients, we know how important quality of life is to people. For some people, that's the most important thing when they're going through this treatment. And I'd say there is research going on in this area, Annabel, but probably not enough. We're getting better at thinking about those issues. And I can give you a quick few examples. So let's think about a clinical trial where you're studying a cancer treatment. What we do now, which we didn't used to do, was measure quality of life for people who are participating in trials all the way along. We call these patient-reported outcomes. And so we're really interested with our new treatments now in trying to understand not only how much longer they might make somebody live, but also how they might change someone's physical symptoms, mental state, sleep, and all that kind of stuff. And we also have a lot of supportive care medications now, which we didn't have 20 years ago. When people think about things like chemotherapy, they worry about nausea. When they think about chemotherapy, they worry about hair loss. These days, we have measures which we can use to try and mitigate those issues as much as possible. And I think they have overall made the experience more tolerable than it was in the past.
Okay, thanks, Shom. This seems like a pretty good juncture, actually, to turn to our third panellist, Lisa Beatty. Lisa is an Associate Professor in Clinical Psychology at Flinders University and a visiting consulting clinical psychologist in medical oncology at Flinders Medical Centre here in Adelaide. Lisa, could you start by just telling us what the impacts are that you see as a psychologist for metastatic breast cancer, and how does it differ from other types of breast cancers?
Yeah, thanks for having me. There's a huge impact, and it's quite pervasive in terms of when people are diagnosed with metastatic breast cancer. We know it can impact on mood and cause things like depression or anxiety, some traumatic stress responses, a lot of grief, particularly in the context of metastatic disease, I think, where you know that this is an illness that at this stage can't be cured. So it's something that people are going to have to live with, and the knowledge as well that they will eventually die from this too, or that at some stage, regardless of how effective the treatments are at this stage, there will be a progression at some stage. And so learning to live with the uncertainty of when that will unfold and learning to live with the fear of progression is something that makes it particularly challenging, I think, in the context of metastatic breast cancer. But yes, and then there's also huge impacts in terms of knock-on effects to family well-being and concerns for family and friends and how others and loved ones are going, and also in terms of their ability to work. And we know that work and continuing to work can actually be quite protective for some people, whereas for others it's, that might be something that they actually decide to reprioritise and spend their time elsewhere. But yeah, so it can be really quite a pervasive, holistic, all-encompassing impact.
I'm really interested, Lisa, knowing that, so for some people who are successfully treated for breast cancer, who then fear that later they may have a metastasized return, it's a shocking fear to feel stalked by. And I wonder, as a psychologist, how early do you start talking to breast cancer patients about how to handle that worry? Because I guess on one hand, you don't want to, scare them with more stuff than the scary stuff that's already happening to them, right? But also you want to make sure that they have a framework for thinking about that, if it happens.
Yeah, absolutely. So one of the things that we often do for women when we're working with them with early stage disease is actually talking about the fear of potential recurrence. And there are some evidence-based treatments. We're actually really lucky here in Australia. We've pioneered, a really great evidence-based treatments on targeting fear of recurrence. And that's learning to actually navigate the idea that, yes, it may be a possibility, but it's also learning to redirect your attention and focus on what's important and meaningful to you in the current time, and setting goals for yourself to live by so that you're not constantly getting preoccupied with what may come down the track. So that's a really, as I say, evidence-based treatment called Conquer Fear that has been developed by one of the clinical trial groups here in Australia I've had the privilege really of being able to roll out where I treat patients. So that's in the setting of early stage disease. And then many of those same principles apply once you're working with women once they've been diagnosed with metastatic disease, about helping them to live in the present, notice when they're getting hooked with fears about what may come to pass down the track, and then redirecting their attention back to what they can do in the present moment to live well, while acknowledging that those fears will pop up from time to time.
So what sort of resources are there around for people who have developed metastatic breast cancer? Where do they go first? Is it a bit of a confusing panoply of options, or where do you start?
Yeah, I think one of the things that I've often heard women saying is that sometimes it can seem like, compared to women who've got early stage disease or people who've got early stage breast cancer, where there seems like an abundance of resources available, that often people with metastatic disease might feel like there's a very restricted range, much less available to them. But there are increasingly more resources being made available. So, for example, the Breast Cancer Network of Australia has put together the My Journey kit online. And it used to be that this was just for women with early stage disease, but they've now really expanded the range of resources through that. And you can tailor it so that it is specific for women with metastatic disease. So that's one example. The Cancer Council has got a range of resources. There's even now, I've been hearing about a support group that's dedicated for women with advanced breast cancer called the Advanced Breast Cancer Support Group. that they've been developing their own resources as well. And then through my own research, we've been developing online resources for women with metastatic breast cancer specifically as well. So they're kind of some of the resources that people can access themselves. But then outside of that as well, we do through Australia, through Telehealth and through Medicare, there's also access to mental health clinicians for those that might need more specialised support when they're feeling like their distress is really starting to escalate a little.
Now, Lisa, I don't want to make gendered assumptions, but obviously we know that this is a disease that overwhelmingly affects women, although not exclusively. I've noticed that of the women that I know that have had breast cancer, and in fact, really women that I know that have families and have cancer, they often spend so much time and energy pouring into supporting the people around them,
Yes.
protecting their children, protecting their loved ones, and, you know, looking after the responses of other people. How do you, I mean, what are the techniques to break down and make sure that that women are taking care of themselves as well?
I mean, that's a great question, because I think it is so, I don't know, built into us to look out for those around us. And a lot of the time, these are going to be women that have got caring roles, whether it's for ageing parents or for loved ones or children, dependent children. So I don't think there's a quick switch that you can flick off to suddenly go, okay, I'm going to just focus on me now, because quite often women I've worked with will end up saying that drives up the guilt. So I think what we do often end up saying though is, we bring out a metaphor of, back in the day when you could actually go on aeroplanes, which in the current COVID climate we don't. But, when you're supposed to get on an aeroplane and they're going over the safety instructions about what do you do in the event of an emergency and the oxygen mask drops down, you have to put an oxygen mask on yourself first in order to be able to actually look after those around you. So we'll often pull in that same metaphor here about you're no good to anyone else around you if you're actually also not prioritising and looking after yourself and your own well-being during this time.
That is actually sort of strategically brilliant, because you're kind of using the guilt instinct to actually bring about a behavioural response. I mean, it's diabolical and brilliant, but like, what about for the people who are around, these women and desperately love them and are terribly worried for them, and of course are consumed by the uncertainty of the future in these circumstances? Like, what? People don't know what to say, don't know whether, whether whatever they're going to say is the right or wrong thing. I mean, are there right and wrong things to say?
Oh, look, beyond the good old, I think there's even been little memes and things set up about, if I tell you I've got lemons, don't tell me that lemons killed this person that only 3 days later. Obviously that's an example of the things not to say. But I think the thing I hear more often, rather than that people said the wrong thing, was that people just disappeared entirely. And the people that they weren't expecting, that they'd been really close, key support people all along, had suddenly just vacated themselves. And I think that's quite often because of that fear of not knowing what to say, of feeling deeply uncomfortable about the potential mortality, and just, that they just don't know how to respond to it, so they just don't say anything at all. And then it gets to that point where enough time has passed where it suddenly becomes extremely awkward, and it's, how do you resume contact after that time? So honestly, my advice here would be it's better to actually jump in and say anything, because you can apologise for saying the wrong thing, whereas it gets a lot harder for just disappearing completely. It's
interesting, isn't it? I remember my colleague Lee Sales wrote a book about ordinary people undergoing, dreadful and sudden disasters. And I just finished reading the manuscript for that book when Lee's father died, and super suddenly, and she was very close to her dad. And as I drove over to her house that day, I thought, oh my God, I've just read the most useful book possible on how to deal with people that have just had a horrible shock. And, it was the author that I was going to visit, but that's the thing that I really picked up out of it, is that you really, it's almost a bit egotistical to think that you can make someone's day worse that's already having a dreadful day by, some stupid thing that you might say. The more important thing is just to be there and maybe even say nothing, but just to signal with your voice and your presence that you're there, and that that you don't have to be looked after, that you're just there to help, or just provide a warm body, right?
Absolutely. And it's also really important to know that we don't always expect everyone to be providing the deep and meaningfuls for us. There's a range of different ways you can provide support to people. Yeah. It doesn't have to be emotional. So if you know that you're great with cooking a meal, or you're happy to be a taxi, or you're happy to go and pick up kids from school because you know that your friend or loved one is not going to be capable on that day, you can offer those more pragmatic types of support, or you could hunt down some relevant information, or go to medical appointments with them and be that second set of ears for them. So there's other ways of offering support that doesn't just have to be sitting there and having the deep and meaningfuls.
It's interesting you should raise that, because I think some people feel like they're obliged to come up with some sort of profundity, whereas I guess after you've had the 25th profundity of the day, maybe you'd rather just have a sausage roll or something.
Absolutely. Yeah. And there are plenty of people as well who actually would really not like to not focus on their cancer for a bit. So if they've got someone in their support network that would distract them away from it and give them 5 minutes of thinking of something other than cancer, they would be really appreciative of that too.
Yeah. Sometimes a bit of a laugh is handy too, right? Which is counterintuitive, but black humour is an amazing thing. Listen, I wanted now to just play another little video. This is about the CAPTURE clinical trial, which Breast Cancer Trials is coordinating in Australia, and Sarah-Jane, fortuitously enough, is heading it up. So I'm just going to play the video now, and then we'll have a little chat to Sarah-Jane about what it all means.
The CAPTURE clinical trial is for patients with advanced estrogen receptor positive, HER2 negative breast cancer. Current treatment for patients with this disease can involve endocrine therapy, chemotherapy, and sometimes targeted therapy. But we know over time many of these patients eventually become resistant to endocrine therapy options. The CAPTURE clinical trial is really looking at individuals who have developed resistance to their endocrine therapy and seeing if we can overcome that with new targeted therapies. And if that treatment option is effective, we would hope that we would be able to prolong the lives of individuals who have this type of breast cancer. But in parallel to that, we also hope that these treatments will be easier to deliver, more effective, well tolerated. And finally, we're also hoping to develop better tests to be able to identify which patients are more likely to respond to these types of therapies. So the CAPTURE clinical trial will actually, through a blood test, actually test for the presence of this particular change in the gene PIK3CA, and that's certainly much simpler than trying to do that on a tissue biopsy, which is how we've done this before. We'd be hoping to see that the targeted therapy, which is a drug called alpelisib, actually leads to improved survival for patients compared to standard chemotherapy. If the trial is successful, then we would have identified a new therapeutic option for these patients. Having blood-based tests where we can hopefully identify which patients are most likely to respond to these therapies would be a huge step forward.
Thanks so much, Sarah. And as promised and advertised, I'm going to start with a stupid question, which is, of breast cancer patients in Australia, what sort of proportion have the kind of breast cancer that you're addressing here?
Yes, that's a good question. So it's around 40% of patients that have hormone receptor positive or estrogen receptor positive breast cancer would have this type of breast cancer that carries a fault in a particular gene, which is called PIK3CA.
Right, okay. Well, that's a big chunk of people then.
Yeah, absolutely. And, for a long time, my research has been very focused on trying to develop special types of blood tests that can help try and identify the best treatments for different patients. Comes back to the concept that Shom raised about precision or personalised medicine. If we can understand more about an individual's cancer, then hopefully we can treat it more effectively. And if we can get that information from a simple blood test and identify the features of one's breast cancer, then hopefully we can plan treatments for those patients more effectively.
So how did it come about? I'm just interested in the process of how you go about identifying a field of enterprise and orchestrating a trial of this size.
So really, I guess, initiated, a decade ago when I got interested in developing blood-based biomarkers for cancer, and could we actually use blood tests to help understand the features of the cancer. And so through developing those tests, we've wanted to try and understand the applications of those tests in clinical practice, and that led to, developing clinical trials where we're utilising these blood tests to identify patients that have this particular type of breast cancer, and then seeing if those patients actually respond to this particular type of targeted therapy because of the type of breast cancer that they have.
What type of therapy do those patients typically receive now, and has it changed much over the last decade or two?
Yeah, so these are patients with metastatic estrogen receptor positive or hormone receptor positive breast cancer, and there are a number of different treatment options for these patients. Typically, they would be exposed to hormone therapies and chemotherapy at different times during the course of their treatments. But this is a very special type of targeted therapy that helps target the pathway that the PIK3CA gene controls.
Okay, so I guess the obvious question is, well, how's the trial going, and when are you expecting to see results?
So we've recruited 26 patients to the trial, and the aim is to recruit a total of 140 patients. So we're sort of nearly a quarter of the way through the trial at the moment. The trial is progressing very well in terms of the fact that the treatments are well tolerated. It's too early to really understand, I guess, the effectiveness of the new treatment thus far, but we really expect that we will have some results really in the next 12 months, depending on how the recruitment continues to progress.
It's interesting because we did get a few questions from people about how they can find clinical trials in metastatic breast cancer and join a trial. So often I think it feels to people like, they sort of stumble over the right clinician, or they know somebody or hear about something. How can people most easily find out, what's going on in terms of trials and participate if they possibly can?
Yeah, I think one of the first ways is, asking your oncologist. So your oncologist or your treating physician will usually have a good understanding of the types of clinical trials that are available in your region or even outside that, and what might be most appropriate for your type of cancer. Mm-hmm. And then other resources, of course, breast cancer trials have a wealth of information about current breast cancer activities that are happening across Australia and New Zealand, and, are there certainly to direct patients and provide information on current opportunities.
Shom, did you have anything to contribute on that? I'm just interested in your views and experience on how people get involved in trials.
Look, it is, as Sarah-Jane mentioned, it's a complicated area, and I think that's why it's hard for people. How do you know what trials are out there? How do you know which trial is right for you?
Yeah.
Often these trials have got eligibility criteria, which are all buried in the fine print. So even if you think a trial's right for you, it's not, or vice versa. Mm-hmm. And so you really do have to use, there are databases online you can look at and whatnot, but you really do have to use your oncologist as a sort of point person to give advice there. And if they are not, buried in the world of trials, they will have channels to oncologists in the big academic centres who certainly will. And we really do monitor the trial landscape really closely, but you've got to ask. It's one of those things that some oncologists, if they don't get asked, they may not raise it with you.
Yeah, right. Is there a bit of a nervousness about being part of a trial? I mean, do people sort of think, well, if hang on, a trial sounds a bit sort of dicey or might not work? I mean, is there an understanding gap around what trials can achieve and what they can offer to a patient right now?
Yeah, it's interesting. I've seen it go both ways. So I've seen some people who are super interested in being part of a trial. Yeah. The idea, first of all, that they might be accessing a new treatment, which would help them, which they wouldn't otherwise be able to get. Or just the fact that they're helping move the research field forward in general can sometimes make those people. Yeah. On the flip side, you do often hear people who are concerned that, is this an experimental treatment? Has it been tested properly? Is it safe? And also a lot of the trials that we do are what we call randomized trials, where you join the trial and then you're randomly assigned to treatment A or treatment B. And some people find that a little bit disconcerting.
Right, okay. And in this world where, I mean, you know, everybody's an epidemiologist now, right, as well as a climate scientist now that we've got the internet, has the advent of Dr. Google made it harder or easier for treatment of people with cancer?
Look, I think overall, I think the internet has served a great purpose to patients with metastatic breast cancer. It's amazing how there are some really good sources of information out there, some really productive forums and chat rooms and things like that where people can get together and share experiences. And it just empowers people. You know, I have people coming in to see me in clinic asking very sophisticated questions about their illness and how it should be treated based on things that they've read online. There is another edge to that sword though, and you know, that is that there is some information out there which may not be entirely accurate or, you know, intentionally or, you know, more likely unintentionally is fear-mongering. And so that's a tricky one, is to know when you're reading something, just like anything we read in the news these days, how to know when you're reading something that's reliable fact versus something else. Well,
obviously you just stay with the ABC and you don't have any problems at all, Shom. So is there anything, and I'd be interested what the other panelists have to say about this before we turn to the questions from our audience. Like, what phrases should you not Google?
It's a very good question. I think anything's, I'll speak my opinion. I think anything's fair game on Google. But if I had to sort of warn people against something, I would be leading with negative, searching for negative experiences.
Yeah.
You know, like, you know, I mean, look, there are people who have difficult times with this disease. We all know that. But it's true that people who have had a difficult time are more likely to express that than people who are feeling pretty well and getting on with life. Yeah. And so when you search for these negative experiences, it's just like, you know, looking at the reviews of a restaurant or whatever, you just go straight down to the 1-star reviews and you think, oh my goodness, this is a disaster. But often they're not really reflecting the true picture.
Gee, that's such a good piece of advice, I reckon, because the human brain is a bit geared to catastrophize in situations of stress anyway, right? And sometimes I think the World Web is not always the best thing as an antidote to that natural human tendency. Were you trying to say something, Lisa?
Oh, no, I was just completely in agreement there with Shom that, you know, most of the time when people go and search things on the internet, the worst case scenario is going to be the thing that comes up. And in the same way that I've had lots of people say to me that when they've joined support groups or chat groups or forums, that quite often they've ended up feeling quite overwhelmed from the experience because they're always going to hear from people who are, you know, I mean, the people that tend to be drawn to those groups in the first place are those that might be struggling a little bit more. So it's not necessarily reflective of the overall picture. So yeah, no, I completely am in agreement with that I think that anyone who is searching for information on the internet needs to be very cautious and needs to be really mindful of the sites that you end up selecting, because there are some really fantastic credible sites. So anything that tends to be more government-based, you know, or Cancer Council or BCT, you know, anything that's a little bit more of a scientific or government-based website tends to have more credible information. Whereas, you know, the internet can take you down any rabbit hole if you're not careful.
Maybe not the Joe Rogan metastatic breast cancer page then.
Exactly.
I guess it's true, isn't it, that people, I mean, you know, even people undergoing the same experience, you know, 2 people with metastatic breast cancer will have massively different ways of coping with it, right? For some people, it's, I'm going to go to the darkest possible outcomes and I'm going to grapple with those so that nothing surprises me. And then the next person might be like, I'm more of an optimistic person, so I'm going to fix my gaze on, you know, the best possible outcome and work towards that. And both of them are kind of right for themselves, I suppose, because that's just the way they deal with it. But I guess it's difficult when those 2 people meet each other because they could really freak each other out. So how hard is it to assist patients to have faith in the tone of their own response to what's going on?
Yeah, I mean, I think that you've hit it spot on there, that there's actually no right or wrong way of coping with a diagnosis like this. It's just about whether it's working for that individual. So, you know, if someone wants to focus on what may come, and that's the way that they process. They want to do a lot of internet searching. They want to speak to a lot of people about it. You know, they really are the information seekers, and that's actually what helps them. Then that's fine. But then if they're trying to relay that to someone else, you know, that they might know in a support group or whatnot, and that other individual actually tends to cope much more through just putting their trust in their doctor. They don't want to do any internet searching. They don't want to find out about what might come down the track. They're really wanting to filter things in one step at a time. Then that's where that clash may potentially happen and cause each individual in that interaction distress, because it's just really so opposite to their way of coping. And as I say, the key thing here is that neither person is right and neither is wrong. It's just about what works for you as an individual.
Okay, well, speaking of individuals having individual experiences, we've got so many questions that have been sent through by people with burning curiosities and concerns and fears. So I'm just going to work through them and some of them I'll throw to you individually, and some of them I'll just sort of open up to the panel. The first one is super timely, I think. What impact has the COVID pandemic had on treating people with metastatic breast cancer and also on the provision of support services? Anyone can jump in on that one.
I think that the pandemic has certainly shone a light on the importance of early diagnosis. I guess we've heard a lot about, patients maybe putting off seeking help or advice for particular symptoms that they may have. And I think it's just reinforced the importance of, seeking help if you need it, if there's anything that is concerning to you. I guess we have, at times during various periods during the pandemic, depending where you've been located, a lot of healthcare has moved to telehealth options as well, which has maybe impacted on the ability of some patients to access face-to-face care. So there's another thing that may have, impacted on, one's ability to potentially seek support as well. But I'm sure the other panel members might have some comments on that too.
Yeah, I would agree with that. And, based on my experience with my patients, I would say for patients, it's been really hard. And I think that one emotion that I keep seeing coming through is fear. It's a scary time already when you've been diagnosed with metastatic breast cancer. Now people are hearing that if they have cancer and they get COVID, they're more likely to get really sick. If they're on cancer treatments, the vaccines are maybe less likely to work. They're afraid to come to hospital because they might get COVID. Support groups are shut down because people can't sit together in a room. You're admitted to hospital, your family can't visit you. I mean, it's just hard to quantify how many ways this pandemic has made it very, very difficult for people. On the other side, thankfully in Australia, at least where I'm working, and I think around the country, it hasn't impacted hospitals' ability to provide treatment, but the treatments that we use for treating metastatic breast cancer have gone on. There's a phrase that we often use in the hospital, which is cancer hasn't taken a break just because of COVID. And thankfully, we've been able to keep giving treatment, but that's only a part of it. The impact in other ways has been really, really big.
And I'd also like to just advocate, if possible, that there has been some silver linings. And it sounds weird to say that, but telehealth was not nearly as widely adopted as it is now. And I've heard of some people saying that there's actually been enabled better continuity of care and better access to care in some cases where, for example, for people who are living in rural or remote areas that were having to travel really long distances for a 15-minute medical appointment to then travel really long distances home again, they've now been able to do those sort of routine ongoing monitoring checks via telehealth, and that can be really an important gain in some ways too. And I think it's also shown to us, probably compared to any other point in history, that you are actually able to still maintain some aspects of care, maybe not in the ideal way, but care did still continue in some way, shape or form.
I'd be really interested to know, and I agree with you, like it's just an extraordinary, just the change that COVID has brought about in the way that we work and the flexibility with which we can work, I think, will continue to have really interesting knock-on effects for all sorts of areas of human behaviour. But what has it meant that you can now, if you live in a regional area in Tasmania, you can now access through telehealth expert assistance from anywhere, really? Does it mean much for, I'm hesitant to use the word forum shopping because it's got such a pejorative sort of undertone, but I mean, do people now, are they thinking more carefully about, which expert they want to see, which oncologist they want to see? I mean, does that happen much? Do you know? Might be a bit early to say.
Talk a little bit from my own experience. I think I totally agree with Lisa. The telehealth thing has been massive, and I really hope that it stays. And which is a big topic right now. But my personal experience in clinic has not been that people are using telehealth to sort of seek the opinions of many doctors or a particular doctor. Right now, I think most people are just trying to keep their head above water.
Yeah.
And they're just happy that they can speak to their doctor in any way at all.
Fiona has asked a really specific question, actually, and with COVID in mind. She says, what's the best type of exercise for metastatic breast cancer? Because obviously we all know about the value of exercise for mental health apart from anything else. Is there anything in particular that is a good form of exercise if you're living with this disease?
I think exercise has huge benefits for patients with cancer. I think that it's been underappreciated in the past, and I think we're really starting to really understand just how important it is. In my own practice, there's no specific types of exercise that I sort of mandate or advise patients, but just really encourage that activity because the benefits are enormous, from improved mood, improved well-being, increased energy, reduced side effects from treatments. You really can't underestimate just how important it is.
I guess one of the things that makes people the most anxious, and because this is sort of a most mysterious disease, right? Like something that generates so much fear is, why does this disease sort of choose some people and not others? Is there anything that I'm doing in my lifestyle that makes me at greater risk? Connie asked, why does it occur in some people and not others? And Sarah, I know that there is, not a simple answer to that, but maybe you could give us an idea of how you answer that question when it's invariably put to you by somebody to whom this has happened.
So there are some risk factors for breast cancer and the development of breast cancer, but generally it's a disease that is increasing in frequency and certainly increases as we get older. Why does it metastasize in some patients versus others? I really do believe that that's still a very ongoing area of research. In part, sometimes, for a small proportion of patients, delayed diagnosis plays a role in that. But for many patients, that's not the case. Many patients are presenting early, and yet there is something about their breast cancer that makes it more adept at being able to spread. So I still think that's an area of research that is very important, because the more that we understand it, the more we may be able to prevent it in the future.
Catherine, in a question that I think we captured in that video that we showed earlier, asked, is there any connection between alcohol and metastatic breast cancer?
I can take that one. That's a tricky one. And I think as you saw in the video, it can be one that can make people feel, sort of bring back that guilt feeling, the guilt that if I have a glass of wine, I'm going to cause problems. I think, and part of it stems from the fact, which, the truth is that we do know that moderate or heavy alcohol consumption does increase one's risk of developing primary breast cancer, breast cancer in the first place. That is true. The question is, if you have your treatment for primary breast cancer and everything looks well, does the amount you consume, alcohol that you consume then, change the risk of it coming back? And the honest answer is we don't know. People have looked at this in all kinds of ways. There are some studies which would suggest that it has no impact. There are other studies that suggest it might have some impact. But I think if it does have an impact, it's a small one. And I think that, drinking in moderation is important for all the reasons that we know it's important. So I would advise that to everyone, but I certainly wouldn't want people losing any sleep if they were having a glass of wine here or there in the evening. That's totally fine.
Okay. Glory's asked a question which I'm sure would be front of mind for anyone with primary breast cancer in particular. Can we detect metastatic breast cancer early, and what are the signs and symptoms to look out for?
So again, that's an area where I think that we have improvements to make, and I think where research can help. I think, once an individual has gone through treatment for an early stage breast cancer, at the moment we actually don't have good tests to understand, which patients are at risk of recurrence and when that disease might return. However, there is a lot of work in developing new tests to be able to do that. Certainly the area of blood-based tests in cancer diagnostics has application here. With time, we may be able to develop more sensitive blood tests that we could do on a routine and regular basis in patients after they've been treated for breast cancer to understand if an individual is at risk of the disease coming back. So I think, yes, there is a lot of hope that we can have better tests for this in the future.
Okay, we've got a couple of really big, scary questions coming up. And I know that there's, I don't know, all of these questions are scary for somebody, right? But I think that this question that Jill has sent in would be scary for everybody, which is, it's also one of the hardest ones to answer. So I think I'm going to ask it to Lisa just by way of asking how you normally go about starting to respond to this super obvious question coming from a patient with metastatic breast cancer, which is, how long can I expect to live?
Yeah, and I mean, I think that's the first question that probably goes through most people's minds, when they find out that this is the diagnosis that they've got. And as you've already said, the challenge is that it can be incredibly varied. And so generally what I would be working with a patient with if they were raising this with me is actually about the importance of getting tailored and specific information around their prognosis with their treating oncologist, because we know that there's so much variation in how these metastatic breast cancers can present, and the age that the individual is diagnosed at, how aggressive it is, there's where it's actually metastasized. So all of these things have an impact as to what their life expectancy is realistically going to be. So I think, I'd normalise how scary it is. I'd really talk through, of course, how normal it is to have these concerns and worries, and also, the importance of getting tailored information. That's probably one not to try and Google too much, going back to our topic before, even though it's the first instinct is to go and Google it, but you will not see a happy answer when you Google that. So, and it's not always accurate, as we know. So it's far better to get information that's tailored to you based on your specific cancer history, whether it's, a new diagnosis of metastatic breast cancer versus whether you've had breast cancer previously. So there's so many factors that go into it. It's incredibly complex to make that kind of judgment call, and that's why it needs to be done in consultation with their oncologist.
Shom and Sarah-Jane, I'd be interested in your views about, the parameters of life expectancy that you're aware of in your experience and research and practice.
And as Lisa said, it's tricky because it's really varied, and I won't dodge your question, but I think the reason really is because we now understand that breast cancer is not one disease. There are many different types of breast cancer, and they behave totally differently. Some of them are really tricky to treat, that the treatments don't work for very long periods of time. Others are completely indolent, and people can live with them for a long, long time. So it's really hard to put a number on it that people listening to us today can take home and think applies to them in any way at all. But if you want that sort of broad parameters, I would say, we see patients with metastatic breast cancer on the not so good end of the spectrum live a short number of months. We see a lot of patients live some number of years. And we see some patients who live many, many years. And I've certainly got patients who've been living for decades with metastatic breast cancer. So it doesn't help an individual listening today, but I think it makes the point that you really need to talk to your doctor to ask what is relevant to your situation.
Often with brain cancer, with brain tumours, and this is just in the, recreational reading I've done from people seem to be able to classify them. Oh, this is a very terrible sort of brain tumour to have, or, this glioblastoma is a, nasty kind, or whatever. Does the same sort of thing happen with metastasized breast cancer? I mean, can you actually tell from looking at the critter, how awful it is. Sorry, this is like a really stupid way of putting the question, but, you know, do you know from looking at it, or is it a kind of time will tell situation?
I think it's a bit of both in practice. I think, you know, there are certainly some features of the breast cancer that we can, you know, utilise to gain some understanding of the pace with which it may progress, but also understanding how an individual responds to different treatments starts to give us a greater understanding of how future treatments will be effective as well.
Okay. Another sort of huge question that came in from Julie, which I'm sure would be super front of mind for anyone who is currently living with or who has been successfully treated for a primary breast cancer. What is the likelihood of cancer returning for breast cancer patients? Let's just say among patients that have been successfully treated.
So I can take that one. What we're talking about, I guess, are patients who were originally diagnosed with primary breast cancer. Non-metastatic breast cancer, they might have had surgery, maybe they had some other drug treatments, maybe some radiation, and then at some point they're told, your treatment's all done. And the question is, what is the likelihood that it's going to come back somewhere else in my body? And again, it's so varied. It depends on the type of cancer. Overall, amongst all patients with primary breast cancer, it's somewhere in the order of 20 to 25% of patients that do experience metastatic recurrence. But again, just to give you an example, I saw a patient recently who I told her chances of developing recurrence were less than 1%. And I have seen other patients where I've said, look, it could be as high as 50%. So it's super varied depending on the context. But that's a big picture number, is that 20-25%.
Okay, I'm going to throw a couple of more technical questions to you, and then I think we'll have a little bit of a talk about side effects and a bit of hope for the future. A number of people who threw in questions for this panel have asked specifically about the URSO compound and where this is up to. Now, I have never heard of the URSO compound, and I'm, you know, quietly confident that you will have. I might throw this to you, Shom. What is the URSO compound, and why is there so much interest in it?
Yeah, it's an interesting one, Annabel. I'm fascinated to see that there's been a lot of interest in that from the people watching today. URSO is basically a name for a new drug that's being developed by a research group, an academic research group in the US. And it's being put out there as a possible new treatment for what we call hormone receptor positive breast cancer. It's about 2/3 of all breast cancers. And it basically is thought to work by binding to that estrogen receptor in those breast cancer cells, which triggers this whole biological process and ultimately kills the cell. And the lab studies that were done, and were only published last year, so it's very hot off the press, were really promising. And that led to this huge movement of URSO activism, which is really taken over on the internet. It's quite fascinating. And but yet now we've hit this point where everything seems to have stalled. It hasn't entered human trials, and it's a bit controversial why that is, because the company that took over the development of URSO was thinking about potentially discontinuing its development, but wasn't really totally transparent about why that is. So it's a little bit uncertain right now how it's going to play out. But it's really interesting to me just to see how much traction that compound has gotten out there online. And to be honest, it's not one that we are yet even really thinking about giving in patients in trials.
Okay, all right. So don't get too excited about the URSO compound is what I'm getting from your answer. It's amazing, isn't it, how these things go a bit viral, isn't it? Okay. I also got, look, this is going to be a spring on all of you, because I got an email from Professor Fiona Stanley, who had a question for the panel. And I just think when Fiona Stanley asks you a question, you just see what you can do to get it answered, right? So she asked, I have a question on the current state of understanding of the value of measuring tumour markers in addition to estrogen, progesterone and Herceptin. Are they helpful in determining chemotherapy options? Love from Fiona Stanley. Shom, I saw you nodding a bit. Does that mean that you might be able to help us?
I can briefly touch on it, but I know that this is right in Sarah-Jane's wheelhouse.
Oh, I'm sorry.
She's an expert on this. I mean, there are lots of different types of tumour markers. Some of them are blood tests, might be what we're talking about. Some of them are things we measure in cancer tissue itself. And depending on the type we're talking about, we sometimes can use certain markers to learn more about someone's cancer.
Right.
We might say, because your cancer has marker X, we're going to give you this drug. Right. We're going to give you that drug. But there are other markers that we use sometimes for patients with metastatic breast cancer, which just are trying to give us an overall sense of, is your cancer responding to treatment or not? People get very focused on those numbers, and I would say we use those as a guide, but they're not absolutely reliable markers of how the treatment's working. Okay,
Sarah-Jane?
Yes, I think that was an overview. I guess there's more than one type of tumour marker that can be utilised. As Shom indicated, in common practice over many decades now, we have used types of markers that gives us an overall picture of whether a cancer is responding or not to treatment. They're not elevated in all patients, however, is a problem. So in some patients they're very effective, in others they're not effective at all. And they don't really tell you any specific information about the individual characteristics of one's cancer. However, there are new tests on the horizon. Some of the blood-based tests that we're involved in developing really look at analysing tumour DNA that's shed from a patient's cancer into their bloodstream and analysing that DNA. So we have a much more sophisticated sense of what are the characteristics of that breast cancer and how it's changing over time. And I think that has real power and potential in the future to give us personalised information for an individual in terms of what treatments may be most effective and how an individual is responding to those treatments.
Okay, I'm going to put the next one to you, and thank you for that excellent performance under duress and with no notice at all. Breast cancer, this is a question that I'm going to ask you to answer too, Sarah. Breast cancer trials has received a lot of questions in this process about triple negative metastatic cancer. I don't know what that means, and I'm sure I'm not a Robinson Crusoe. How common is triple negative metastatic cancer, and where is research up to with this variety?
So triple negative breast cancer is a distinct type of breast cancer. It's not the most common type of breast cancer. Probably around 10 to 20% of breast cancers are so-called triple negative. What that triple negative really refers to is looking at particular markers that are expressed on the surface of cancer cells, and it's looking at three markers: estrogen receptor, progesterone receptor, and something called HER2. And a triple negative cancer is a cancer that is negative for all three of those markers. Mm-hmm. So it's by far the minority of breast cancers that are triple negative. And there's intense research effort into this area in terms of how to develop better treatments for this type of cancer. Traditionally, chemotherapy has been used to treat triple negative breast cancers, but there's new therapies being developed all the time. One example would be the advent of immunotherapy, which is a type of treatment aimed at harnessing a patient's own immune system to target the breast cancer. And there's a lot of work in trials at the moment to understand how we may be able to utilise immunotherapy in combination with other treatments such as chemotherapy to get effective responses in patients with triple negative breast cancer.
Okay. Diana has asked a question which I think is probably a big one for lots of people listening, which is, what about research that into the prospect of preventing breast cancer from metastasizing? Is that a field of research that offers any hope?
It is, and I guess there's many ways to think about that. So if you think about what might happen, someone's diagnosed with breast cancer, they have their treatment, but then if that person is destined, unfortunately, to develop metastatic breast cancer, what that must mean is that even after all that treatment, there are some breast cancer cells hiding out somewhere in the body that we can't see. And a lot of focus is really on trying to find drugs that can take care of the cells at that point to prevent them from then outgrowing years later into a metastasis. And so a lot of the new drugs that we're developing, our greatest hope for those drugs is that they will do exactly that. when you get more into the science and ask, what about breast cancer cells, the way they invade into the bloodstream and how can we target that? Sarah-Jane said earlier, that's still a subject of lab research, I think, but we don't have drugs or other treatments that are specifically aimed at that, targeting that biological process.
And are there any ways that patients can minimise practically their chances of a metastasis? I mean, it's such a huge question, obviously, and there are always things that we can do to be healthy in our lives. But is there anything that we know that is therapeutic or useful in reducing that risk?
I'll have a stab at that one. We do know that, in terms of what we call secondary prevention, there are lots of behavioural things that people can do in terms of trying to lead healthy lifestyles. So how much it actually will have an impact is still, I think, needs to be researched. But just, you're not going to do yourself any disservice anyway in terms of, exercising, focusing on moving your body that you can do. So exercise, good nutrition, also things like stress management. We know one of the things I actually really wanted to highlight here is that there's a lot of public misconception that stress causes cancer or might cause a cancer recurrence. And we know actually that it's been really heavily researched and there's no evidence to support that. So I wanted to actually really make that clear too, that often people get stressed about being stressed, thinking that it's going to, that they're, being stressed is going to cause their cancer to recur. So I think, while it won't necessarily cause the cancer to recur, we certainly want people to be looking after themselves. So we know that, some of these behavioural factors in terms of if they're smoking, if they're drinking alcohol to excess, and I'm making clear that it's to excess, doing some of those lifestyle modification factors will really help reduce their risk of secondary cancers across the board, because we also know that, in terms of these are the same factors that actually reduce the likelihood of cancers onsetting in the first place. So, yeah, I think that's always important to look at, the behavioural things that you can do.
And I know it's a sort of unfair thing to ask you to reflect on the view of conventional cancer researchers and scientists and medical health professionals across the board, but what is the current view of alternative treatments like naturopathy, diet, vitamins, acupuncture? I mean, I guess in the olden days, there was a lot of skepticism about those things. Obviously, there's a lot of enthusiasm from various non-professional practitioners and advocates and influencers and so on. Where does conventional science stand on all that stuff at the moment?
So maybe I can start. I think in terms of a balanced, healthy diet, and the other one that I would say is acupuncture. I've had many patients that have actually had good benefits from acupuncture in terms of sometimes treating side effects or other cancer-related symptoms. The one I would be cautious about is, I guess, vitamins and naturopathy. There can be many unrecognised interactions between alternative medicines and standard therapy. So it's always really important, if you're going to take anything, to discuss it with your oncologist, discuss it with your pharmacist, and just ensure that there is no drug interactions that may impact on the success or the effectiveness of any standard treatment that you're taking.
Great advice, thank you. Rain, these questions are still coming in, so we are seeing them. So if you have something that you're itching to ask, please just hit that button and ask the question. And Rain has asked a really good one, which is, are there still gene mutations to be found? She says that she has a family history of breast cancer, but has tested negative for BRCA1 and 2. Are there still gene mutations out there?
Yeah, it's a great question. So, there are some people out there who have developed breast cancer because they carry a mutation in some gene that has put them at really high risk of breast cancer. And BRCA1 and 2 are the classics that we all know about. And they probably do account for the majority of what we call hereditary breast cancer. However, there are other genes There's at least a few more that we really do understand. And these days, when people go for genetic testing, if they qualify for it, they often get what we call a panel test, where we don't just test for BRCA1 and 2, but we look at some other genes as well. There's still a group of people out there who have a really heavy family history, and we just do not know what the gene is that's driving it, or if there's a gene driving it. That group of people still exists, but certainly there are more than BRCA1 and 2.
Elaine asks, how do you know when breast cancer has spread?
So it can sometimes be difficult to know. Sometimes patients present with particular symptoms, but those symptoms can be varied. And I often get asked this question from patients, how will I know? And the honest truth is, eventually it might declare itself with symptoms that get investigated and a diagnosis of metastatic disease is confirmed. But those symptoms can be very varied. So it's difficult even on this discussion to pinpoint, 5 common symptoms that may be associated with metastatic disease, because it really depends on the site of that disease as well in terms of how it will present.
Louise has a great and hopeful question, which is, will there ever be a simple blood test to detect breast cancer or metastatic disease?
So this is the area I'm really excited and passionate about, and I really do believe that eventually we will have blood tests to be able to do exactly what you ask. I guess there's 2 parts to your question: a blood test to detect metastatic disease, and I think that that's the first thing that we will actually see being developed, because these tests are sort of well underway. So when someone is diagnosed with an early stage breast cancer, being able to have serial blood tests over time to look for the presence of any residual cancer cells left behind that may eventually lead to metastatic disease. So I think that is very feasible in the future. The second part of that question is, what about a blood test in healthy individuals to detect, to diagnose breast cancer in the first place? I think that that's a greater challenge, but there's certainly a lot of active research to try and improve the sensitivity and specificity of blood tests to be able to achieve that.
There's a follow-up question, request for further information, Sarah-Jane, that's come in for you from Rachel. She says, how can you explain what immunotherapy is and how it might help metastatic breast cancer? It seems to be a buzzword at the moment, says Rachel.
I guess in its simplest terms, immunotherapy is a type of treatment usually delivered intravenously that helps engage or harness a patient's own immune system, activates the patient's own immune system to attack the cancer and treat the cancer. And there's a lot of excitement about immunotherapy. It's certainly had a lot of success in other types of cancers, particularly melanoma is one good example where it's been very effective. In breast cancer, it's been more challenging. It's been more challenging to identify which breast cancer patients are most likely to benefit from immunotherapy, and if the immunotherapy will be most effective if it's combined with other types of treatments such as chemotherapy. So it's an active area of investigation at the moment, how we can utilise immunotherapy best in breast cancer to see the best results.
I wonder, because we're getting towards the end of our session now, and I wanted Lisa to direct a question to you that just broke my heart to read it, actually, because I think it really captures a lot of the experience for many of the people who'll be part of this session today. Robin has asked, how do you get along with your life when cancer is at the back of your mind at all times?
And it's such a hard one, isn't it? It is that whole idea of it's like a sword hanging over you at all times, waiting for it to drop in some ways. And I think, as I was mentioning earlier on, I think sometimes the best thing you can almost do for yourself is to really focus on what is it that gives your life meaning and purpose, and what is that brings you joy. And when you notice yourself getting hooked on those thoughts and worries for the future and what the future might hold, it's about redirecting your attention back to the activities and the people, that really give you that joy and meaning and purpose. We know that the more you can actually live your life as normally as possible and fill up your days with things that give you that purpose, it actually helps to anchor you so that you're not constantly getting I guess, hooked on what the future might bring. So that's, I guess, one of the key things is actually about trying to live as normal life as possible and don't stop things because you're worried about the cancer. It's actually the time to keep as much going as you can.
I'll have a question for you all about, the final question will be about what excites you about the future in this field. But I just noticed, and I don't like to miss anyone out, that Michael has just popped in a question for Shom, which is there any research targeting lobular breast cancer?
Yeah, so Michael asks a great question. Lobular breast cancer, just for people who don't know, it's a type of breast cancer. Maybe 10, 15% of breast cancers are what we call lobular. And what it means is they look different when we look at them down the microscope. They're typically hormonally driven, so we often think of them as being really sort of estrogen-driven cancers. And for the most part, we treat lobular breast cancer really similarly to the way we treat what we call ductal breast cancer, which is the much more common subtype. Just in the last few years, thanks to advocacy actually from patient groups, there has been a real push to look at lobular breast cancer again. And now we're beginning to realize that there are things about the biology of those cells which are different. There are ways in which they might be uniquely vulnerable to other treatments, and also ways in which they may be uniquely resistant to existing treatments. So I would say that there's a lot of stuff coming in that field, and we're probably going to see some steps forward in the next few years.
Great. Okay. Well, thank you. I hope, Michael, that gives you a bit of hope and information. Sarah-Jane, Debbie's just posted in a question saying, which I think is a great one, what is the age at which a family member should be screened, i.e. have a mammogram, owing to a family history of breast cancer?
So that really depends on the family history. It depends on the age at which members of your family may be diagnosed with breast cancer. So if a family member is diagnosed at a very young age, that may prompt screening at a younger age in other individuals in the family, compared to families where the breast cancers may be occurring in older individuals at the age of 60 or 70. So it's individual, and I'd again encourage individual families to seek advice based on their circumstances.
Right. Okay. Listen, finally, because I'm aware that people have got lives to get back to, or we need to wind up. I want to end on, a note of optimism, and I want to ask each of you, what is it that excites you at the moment most about this area of research? What is it that you can't wait to see that's coming up, in the next 5-10 years? And I wonder if I could maybe start with you, Sarah.
So I think there's three things, I guess, that I'm really excited about. I think research into, why some cancers metastasize and others don't. It's been a question that's come up several times tonight. It's really critical for us to continue to progress, because I think a deeper understanding of that will help us eventually reach a point where we may be able to eradicate metastatic disease. I think that the second thing is for patients living with a diagnosis of metastatic breast cancer. I am really excited about the clinical trials, the research to develop new treatments that is out there, because I think that has changed. I've seen it change a lot over the last decade, and I'm very confident in the years to come that new and better treatments will be available that come with good quality of life and help extend life expectancy in patients. And thirdly, you've probably seen how excited I am about blood-based tests as well, and I really think that these tests have a great future in being able to help identify patients at the highest risk of metastatic disease earlier, and the hope is that if we can intervene earlier, then essentially we will have a better chance at curing patients from this disease.
Thank you. You're very inspirational. Lisa, what about you?
Oh, I think it's just wonderful to see how much more research is starting to happen in women with metastatic disease, or people with metastatic disease in general, because, this has often been a population that's been overlooked, and that's also particularly in the case of psychological and psychosocial research. So, we've got some grant funding. We're about to start up an online program for women with metastatic breast cancer in a randomised controlled trial. So that will be happening this year. And there's other trials that I'm hearing about as well, looking at how you can implement exercise safely in women with metastatic breast cancer too. So there's lots of really exciting studies that are more broadly in supportive care about helping women and men live well with metastatic disease, because it's one thing to extend the quantity of life, but it's another thing to make sure that they're living well with it as well.
Great. Oh, that sounds very exciting. I'm sure Fiona, who asked earlier about exercise, will be paying close attention to that. And look, I'm glad you mentioned men too, because I'm going to go to you, Shom, to answer this question, because we don't overlook that this disease sometimes does strike men. And Diane has asked, are treatments for metastatic breast cancer the same for men as they are for women?
It's a great question. And, the hard part is that breast cancer in men is pretty rare. It's about 1% of all breast cancers. We typically choose our treatments based on the results of big clinical trials that tell us what to do. And many times, very, very few men were in those trials.
Yeah.
That said, the markers that we look for in male breast cancer are the same that we look for in women: estrogen, progesterone, HER2. And for the most part, we do tend to extrapolate and use the same drugs that we use for breast cancer in women for breast cancer in men. There are some unique situations which can be a bit more tricky because some cancers are very estrogen driven, and the way that you use hormonal medications in men and women can be different. So that's a nuanced point, but overall, for the most part, yeah, the treatments are quite similar.
Great. Thank you so much for answering that. And I wonder if you two could just conclude, Shom, by telling us what excites you about the road ahead.
Look, Annabel, I think I can't list all the things that excite me, but I just wanted people out there to know I am very optimistic. I think that the rate of progress right now is palpable. People are living longer. And I thought if I could just take a minute to tell people out there a story. So a few years ago, I was in San Antonio, Texas, which is where we have a big breast cancer conference every year. And I met a woman who'd been living with metastatic breast cancer for over 20 years. And she sat down with me and she showed me a list of all the different treatments that she'd received over those 20 years. And what occurred to me was that nearly all of those treatments didn't even exist at the time when she was first diagnosed.
Wow.
And basically she had ridden the wave of each new treatment as it had been developed. And in her case, research just kept on delivering her new options just in time. And, I'll admit that that's a special case, but I think it does encapsulate my hope for the future that we will turn this into an illness that people can live with for a long time and live well with. And dare I say it, a little bit further ahead, I think that the goal of cure in certain cases is also not crazy for us to hope for. What we need to keep focused on as a community and as a country and everything is that there is a very strong and direct causal nexus between doing research into this disease and seeing people live better. And so I think as long as we keep that and we keep supporting people out there who are doing that research, there's no reason not to be very optimistic.
Thank you. That's a great story and a great note to end our discussion on today. Listen, I'd like to thank all three of you, really, Sarah-Jane, Shom and Lisa, because, there's such a great world of information out there, and sometimes it seems super confusing to people who have been thrust into this scary world and don't have the experience that you have. So when you find clinicians and researchers who are great communicators as well as experts in their field, it's like a gold mine. And I know that, like anyone who's ever tried to navigate the health system, the discovery of somebody who's knowledgeable and also a brilliant communicator is just an extraordinary thing to find. So I'd like to thank all three of you for your eloquence and the clarity with which you communicate. You can tell by the huge interest in this session that there is a great hunger for information out there. So thank you for taking the time to share some of it to so many people today. This Q&A has been recorded, so it will be available on the Breast Cancer Trials website tomorrow. The team will send everybody a link that you can watch or share with anyone that you can think of who might be interested. Now, Breast Cancer Trials is, of course, committed to improving outcomes for every person diagnosed with breast cancer through clinical trials research. They look to the community to help fund and support support this important research. So if you or your family or friends are capable of making a donation, you can do that via the website, which is at www.breastcancertrials.org.au. This extraordinary explosion in treatment and expertise is substantially powered by this uniquely human attribute that we have, which is the urge to help each other. So it's a very wonderful thing to be able to do. And on behalf of Breast Cancer Trials, I would like to thank everyone who has supported and contributed to, whether financially or emotionally, to supporting people who are going through life with this disease or treatment for this disease. So my very best wishes on behalf of, I know, the whole panel, to those of you who are watching us tonight, and no matter where you are on your experience with this disease, thank you for joining us. The best of luck and life and happiness to you. And thanks again to our panel. Thanks for watching.